Welcome to this presentation on prevention of postpartum depression, sponsored by the International Marcé Society for Perinatal Mental Health. I am Michael O'Hara, Professor of Psychology at the University of Iowa, and host for this program. It is my privilege to have three distinguished prevention researchers join me to discuss approaches to prevention of postpartum depression. They are Mimi Lay, who is Associate Professor of Clinical Community Psychology at George Washington University in Washington, D.C., Cindy Lee Dennis, who is Professor in Canada Research Chair in Perinatal Community Health at the University of Toronto in Toronto, Canada, and Terry Brugha, who is Professor of Psychiatry in the Department of Health Sciences at the University of Leicester in Leicester, United Kingdom. Postpartum depression is a serious mental health problem that afflicts millions of women every year around the world. Symptoms of postpartum depression such as low mood, anhedonia, fatigue, poor concentration, sleep disturbance, and suicidal ideation lead to significant impairment in functioning in areas such as personal care, care of the newborn, family relations, and work. These impairments and the significant suffering of afflicted women call for research on clinical interventions to treat and prevent postpartum depression. Over the past 20 years, a number of psychological, psychosocial, and medical interventions have been validated for the treatment of postpartum depression. Interventions such as interpersonal psychotherapy, cognitive behavioral therapy, general counseling, and antidepressant medication have proved effective for postpartum depressed women. Unfortunately, these interventions, though increasingly available, often are delivered after many weeks or months of suffering on the part of the new mother. As a consequence, many clinicians and researchers have developed programs that aim to prevent postpartum depression. Prevention comes in many flavors. For example, some prevention efforts target entire populations, what is called universal preventive interventions. Examples include childhood vaccinations, water fluoridation, school-based sex education, and childbirth education for expecting couples. Other prevention efforts target individuals whose risk of developing a disorder are significantly higher than average, what is called selective preventive interventions. In the realm of postpartum depression, examples might include targeting low-income women or recent immigrants for prevention efforts. Finally, some interventions target high-risk individuals who are showing initial or minimal signs of the disorder, but not the full syndrome, what is called indicated preventive interventions. A classic example within the prevention work on postpartum depression is to target women during pregnancy that score above a specified threshold on the Edinburgh Postnatal Depression Scale, but who do not meet diagnostic criteria for major depression. Each of these approaches will be represented in the work of my distinguished colleagues. We will start first with Mimi Lay, followed by Cindy Lee Dennis, and then Terry Brugha. Lastly, Cindy Lee Dennis will rejoin me to talk about the findings of her Cochrane review on the effectiveness of psychological and psychosocial approaches to the prevention of postpartum depression. Well, I'm delighted to have Dr. Mimi Lay join us to speak about her work with low-income Spanish and English-speaking pregnant women. She is Associate Professor of Clinical Community Psychology at George Washington University in Washington, D.C. Dr. Lay is a prolific and widely cited author in the area of perinatal depression, and her current work focuses on integrating screening and preventive interventions for women served in the Women, Infants, and Children's program. Of particular interest to our program today is Dr. Lay's studies on prevention of perinatal depression, conducted in San Francisco with Ricardo Munoz and in Washington, D.C. with Deborah Perry. Welcome, Mimi. So Mimi, could you tell us about the origins of your work on prevention of perinatal depression in Latinas?
All of this started in the late 1990s when I first began as an intern and clinical psychology postdoc fellow at the University of California in San Francisco. And I was really fortunate to speak and work with Dr. Ricardo Munoz, who you know is a prominent psychologist with expertise in the prevention of perinatal depression. And at that time, when I started, I really didn't know much about this area at all. And he was really a wonderful mentor in guiding me to do this work. So we began by conducting a longitudinal studies and followed a sample of about 100 women to learn more about their risk and protective factors over time. And then really found that we were able to identify a group who was at high risk for depression based on some of the literature work and also based on some of our work, in which these women tended to be at high risk based on having a history of depression and or having current symptom scores. And then that work really launched our work together and our finding of the Mothers and Babies Mood and Health Project. And really the purpose of that work is to try to increase research in the prevention of perinatal depression for low-income English and Spanish-speaking women.
So could you tell us a little bit about the underlying rationale for group-based CBT interventions for Latinas?
Certainly a long history of very great evidence that cognitive behavioral interventions work in the treatment of depression. And at the time that I came, there was growing research talking about the prevention of depression. And what we wanted to do was to see if this also would apply to perinatal depression. And so if you think about traditional CBT aspects of it, we're really targeting changes in thoughts, changes in behaviors over time. And with the traditional aspect of CBT, the focus has really been on control. Can you actually control your thoughts so you can change them to improve your mood? Or can you control the behaviors that you do? And in some of the work that I've done with Ricardo over time is really making a change of that from the strict control aspects to more of a healthy management of reality aspect. And this is really to try to reflect the people that we're working with. The populations are low income with very limited resources, so they may not be able to have a lot of control over their lives, but can we actually teach them more about how to manage that? So if you could see on the slide that I'm talking about here, our intervention is called the Mothers and Babies course. And what we're really trying to do is to teach women to learn how to manage their personal reality. And that's talking about managing their internal reality. What are their thoughts? What are their values? And how that's connected to their mood. And then also teaching them about their external reality. So things that are in their environment, the neighborhoods that they live in. So they may not be able to manage some of those aspects as much, but we teach them more about learning about pleasant activities, things that they can do by themselves and with their infants, and then things about gaining more social support if they need that to be able to improve their mood. So the idea is to use kind of basic cognitive behavioral strategies, but making it to be more applicable to a low income community.
Great. Now could you tell us a bit about how you tested the group CBT-based intervention and what you found?
It involved probably over the past decade in 3 different trials. The first 2 were randomized controlled trials. The first one was in San Francisco with Ricardo, where we really tested out a 12-week version of this Mothers and Babies course that I just talked about in a small sample of about 41 Mexican women who were immigrant women. Most of this work was done in Spanish. And what we found that, and women were randomized into this 12-week course or into usual care. And these were pregnant women who were at high risk for depression. And what we found was, and then we followed them for about 12 months postpartum. And they also, during the postpartum period, they had 4 individual booster sessions to review some of the main concepts that they learned. And what we found in general, you can see on this slide, was that about 14% of the women in the intervention group developed a new onset of major depressive disorder episodes, compared to about 25% in the usual care group. The difference here was high, but it wasn't statistically significant because of the small sample, but certainly clinically significant. So this really kind of launched my work in DC and doing the second randomized controlled trial with a larger sample of predominantly Central American women. And here I was fortunate to work with Deborah Perry at Georgetown University, who's an expert in early childhood development. And what we found there was there were significant decreases in depressive symptoms from pre to post intervention during pregnancy, but that these changes didn't last over time in the postpartum period. And then when we looked at the incidence of major depression, Interestingly, we found about 8% incidence for the intervention group, but about 10% in the usual care group. So this was really surprising for us. So in general, these numbers were much lower than what we found in San Francisco with the 14 and 25%, and certainly lower in what we think about in terms of the general literature. But there didn't seem to be a difference. So what we ended up doing was to do these exit interviews with a smaller subset of women to really learn more about their experiences in the study, what they learned and what they didn't learn, just to really understand more about why we didn't find these differences. And what we found, if you can look at the slide here, is that the intervention and the study seem to work differently for both women. So for those who were in the intervention group, they really were able to talk about managing their reality and changing their moods through using the CBT aspects that we talked about. But for the usual care group, just by virtue of being in the study for such a long period of time, they really valued the relationships that they gained with our support staff. We did a lot of things to try to recruit and retain our participants, and we provided them with the same types of questions over time. And I think they became a lot more aware of their mood through these questionnaires, as well as through the relationships and support that they got from their staff. And so we think what we had was two different types of interventions that worked. And then we really didn't have a true control group. So for me, really speaks to the importance of doing mixed methods research to understand this.
Yeah.
And then, yeah, absolutely. And then currently, my current work, also with Deborah Perry, is to do more of an effectiveness trial in the community with a federally qualified health center in which we are working with the women in the Women, Infants, and Children's Program, the WIC program, which is, as you know, one of the federal programs that really spans and provides services starting during pregnancy through the postpartum period and to their children over time. And what we have been doing is trying to train nutritionists to integrate depression screening for their samples. And certainly we've had a lot of challenges, structural as well as staff challenges in being able to do this work. But we were able to train some nutritionists to do this, and they were able to screen about 1,100 participants, and found that their rates in WIC, in terms of those who were at high risk, was over 50% of women were at high risk. And so what we're doing is we're recruiting some of those women to participate in a shorter
So what are the practical lessons for us who are heavily involved in clinical care and research on perinatal depression?
Right now. I think one of my sort of take-home messages doing any of this work is the importance of understanding the community that you are working with and being able to do a lot of that legwork ahead of time. So that means having a really strong collaboration with the staff, with the clients and patients in the hospitals or in the community settings that you're doing this work in. So it's important to spend that time to learn about their needs, their unique risk factors, and to learn how the setting works so that we're not being a burden to them. And I know with some of the settings that we've worked with, they've had very negative relationships in the past with research partners and kind of coming and then leaving once the grant is done. And we wanted to be very sensitive to that aspect of it. And because I think we're also working with low-income, very vulnerable populations, it was also really important to listen to their voices from the beginning in terms of knowing what they would want. So I think these relationships take a long time to cultivate, and certainly much longer than our 3 to 6 month startup funds that we kind of say in these traditional grants. So I think being able to build in that time is really important, and then having a bilingual and bicultural staff who's very sensitive to these needs, I think is also really important. And then being in these new settings, there's also the importance of being able to modify to culturally adapt and modify the interventions to make sure that they really do fit into that setting.
Great, thanks a lot. Any last thoughts?
When I was thinking about this, prevention work is just so much harder to do than treatment work. I think in part because historically, and I think from a funding climate, there's less support for prevention. But we do know that prevention of depression and perinatal depression does work, and there's evidence for that. So I think the challenge in this is really trying to figure out how can we sustain the work and being able to provide funding to make sure that there's more of a long-lasting impact in doing prevention work, because this does work and it has a long impact for the women themselves, for their children, for their partners, and certainly for their families. And then I think the other piece in thinking about this work is how do we provide kind of the entire context of integrating this work, starting from integrating the screening to being able to provide the referrals, not only for these high-risk women, but for the women who need more services. So is there a triage in place to be able to do that? And then providing some of the feedback in time. Because again, I think all of these over time will have sort of the multi-generational impact that we all want to work for and are committed to doing for the populations that we're working with.
Dr. Mimi Lay, thank you very much for joining us, and we wish you the very best in your work going forward. We look forward to seeing many future publications from you and your colleagues. I'm really pleased that Cindy Lee Dennis, Professor in Canada Research Chair in Perinatal Community Health at the University of Toronto, has joined me today to discuss prevention of perinatal depression. Dr. Dennis is a prolific researcher who has published over 130 empirical and review papers and is heavily cited for her work in perinatal depression. Of particular relevance to this program is Dr. Dennis's important study entitled Effective Peer Support on Prevention of Postnatal Depression Among High-Risk Women, a multi-site randomized controlled trial, which was published in the British Medical Journal in 2009. Additionally, Dr. Dennis published a Cochrane review in 2013 entitled Psychosocial and Psychological Interventions for Preventing Postpartum Depression. We will return to the findings of the review near the end of the program. Cindy Lee, welcome. Please tell us about the origins of your idea to use women who had previously suffered and recovered from postpartum depression to provide support to women at high risk for postpartum depression.
So my interest in women who provide support to other mothers actually started not with postpartum depression, but rather it started with breastfeeding. I've always been interested in health promotion with new moms. For my master's and my doctoral dissertation, I was focused on the long-standing clinical problem that women often prematurely discontinue breastfeeding before the recommended 6 months postpartum. And the difficulties they encounter were the reasons why they were stopping breastfeeding, not because of maternal choice. So for my doctoral dissertation, I conducted a multi-site randomized controlled trial here in the province of Ontario. And what I did is I evaluated the effect of telephone-based peer support or mother-to-mother support on breastfeeding duration and exclusivity. And what I did is I recruited new mothers who were breastfeeding from the postpartum floor, and I provided them with a new mother in the community who previously successfully breastfed to 6 months postpartum. We provided her with training, and we linked the new mother with the experienced mother, and we called it telephone-based peer support. And what we found is mothers who received telephone-based peer support were 3 times more likely to continue to breastfeed and to do so exclusively than mothers who did not receive this telephone-based peer support. And mothers evaluated this peer support intervention, and they really liked it over the telephone. They enjoyed talking to another mother, and the convenience of having the support in their home was highly rated in the support or in satisfaction evaluations. So I thought, how can I extend this really great intervention? And I thought, well, why don't we try to apply it to postpartum depression as well? And so that's what I did for my postdoctoral work. I pilot tested providing telephone-based peer support with new mothers who might be experiencing postpartum depression.
Great, thank you. Cindy Lee, can you tell us a little bit more about the underlying rationale for peer support as a preventive intervention?
The importance of social relationships in the treatment of disease and the maintenance of health is well documented in the literature. There's also good evidence to suggest that interventions designed to alter the social environment and the individual's interactions in that environment have been successful in facilitating psychological adjustment, aiding recovery, and even extending life for those with chronic conditions. So theoretically, peer support is a type of social relationship. It's the provision of emotional support, informational support, and appraisal support by a lay individual who has experiential knowledge related to a certain target behavior or stressor. And this individual has similar characteristics to the target population or the individual that you're trying to change the stressor or the health behavior in. Peer support can assist with transitional stress. It can assist with chronic and acute situational stressors, and it can provide health promotion and changing health behaviors. What are the potential outcomes of peer support interventions? Peer support can be useful in augmenting support networks, in preventing health concerns, in reinforcing health-seeking behaviors. They can also decrease barriers to care, and that's why they might be very beneficial with socially marginalized groups. They can encourage effective coping through more normalizing of appraisals. They can promote social comparisons, so one mother can compare herself to another mother and normalize certain experiences. And they can increase self-efficacy, so an experienced mother can increase a new mother's confidence in her ability to care for her new baby, and it can aid self-esteem. So based on these certain health outcomes, I thought that peer support would be something very beneficial for new mothers in the early postpartum period.
Cindy Lee, thank you very much. That was very informative. Now, could you tell us a little bit about how you tested the intervention and what you found?
So what I did is I conducted a multi-site randomized controlled trial to evaluate the effect of telephone-based peer support for the prevention of postpartum depression. And I did this in 7 health regions across the province of Ontario. So we had rural health regions, we also had urban health regions. And we recruited over 701 women in the first 2 weeks postpartum who I identified as potentially being at high risk to develop postpartum depression. And in this trial, we identified high risk as any mother that had an Edinburgh Postnatal Depression Scale score greater than 9 within the first 2 weeks postpartum. My research has clearly shown that how a mother feels in the early first postpartum weeks is very similar to how they feel at 4 and 8 weeks. So this is early identification of mothers with beginning depressive symptomatology. So this is not a primary prevention intervention, but rather a secondary prevention or an indicated. And with these 701 mothers, half of them were randomized to a control group, which was just standard care that all mothers would receive in the early postpartum period, or half of them were randomized to the telephone-based peer support. And that was proactive, individualized support over the telephone from a peer who was another mother that we recruited from the community who felt that she previously experienced postpartum depression and had recovered, and she participated in a 4-hour training session with me. And in that training session, what we focused on was not the experience of postpartum depression, but rather how to develop a relationship over the telephone, how to provide effective support, and how to refer a mother to healthcare professionals. I conceptualized, this peer support and this peer volunteer as an individual who is a mediating link between mothers in the community and healthcare professionals. And then what we did is at certain time periods across the postpartum period, so at 12 and 24 weeks postpartum, we administered the Edinburgh Postnatal Depression Scale. We did a diagnostic interview with the SCID. We assessed for anxiety, loneliness, and we looked at health service use. And what we found is that we were able to screen over 21,000 women across the province of Ontario. We were able to recruit 701 mothers, that's 72% of mothers who were eligible and agreed to participate in the study. A blinded research nurse followed up with more than 85% of mothers by the telephone. including 613 mothers at 12 weeks postpartum and 600 mothers at 24 weeks postpartum. And at 12 weeks postpartum, we found that 14% of women in the intervention group, so the telephone-based peer support group, had an EPDS score greater than 12, and 25% of mothers in the control group had an EPDS score greater than 12. The number needed to treat was 8. The relative risk reduction was 0.46. So what we did is we basically cut a mother's risk in half of developing postpartum depression, defined as an EPDS score greater than 12 at 12 weeks postpartum. So what we can deduce from this trial is that telephone-based peer support may be an effective intervention to try and prevent postpartum depression in mothers who have beginning depressive symptomatology early in the postpartum period. Mothers had an opportunity to evaluate their peer support experience. There were many positive accounts of their experience, minimal sources of harm, and peer volunteers also enjoyed providing the telephone-based peer support, and they felt that they grew as individuals when they provided it.
Thank you. Cindy Lee, what are the practical lessons for us who are heavily involved in clinical care and research on postpartum depression?
I'm not a clinician, so I can't really say about what are the direct clinical applications of this, but what I can talk about is general ideas that I have around the prevention of postpartum depression and where we should be going research-wise and what are the implications. First of all, I think that we should be doing a step care approach to the management of perinatal depression. And of course, the first step is early identification. I think that that can be done earlier in the postpartum period rather than later in the postpartum period. And if we do identify a mother with beginning depressive symptomatology, maybe perhaps the best first step is something around the prevention of postpartum depression, a secondary preventative intervention, something that's very easy, such as telephone-based peer support. I also think that we need to start focusing a little bit on fathers. First of all, they also experience postpartum depression. A meta-analysis suggests that 10% of them will experience a depressive episode within the first 12 months postpartum. And there's growing evidence to say that there is a strong relationship between maternal postpartum depression and postpartum depression, with one of the strongest risk factors for paternal postpartum depression being past psychiatric history, like mothers. But also, if the mother's experiencing postpartum depression, that places the father at increased risk. So I think that we need to start looking at the whole family context in the early postpartum period and what supportive resources are available for that family and how well are they adjusting to this new transition. So in that same thought, I think an innovative intervention that would assist the family in this transitional time period would be an intervention such as co-parenting. The characteristics of co-parenting are increasing the couple's capacity to problem solve, to manage conflict, to have productive communication, and to provide support to the other's parenting role. It works to increase effective communication, cohesion, and flexibility with the parenting relationship to help the couple meet their parenting goals. It has been shown to increase demonstration of respect with the couple, to acknowledge the other's parenting strengths, so to support the couple when they're in stress, and to increase parenting self-esteem. And I think that when we look at the risk factors for postpartum depression, and we know how important that partner is in the postpartum period, I think potentially exploring the value of a co-parenting intervention might be a very important preventative intervention.
Cindy Lee Dennis, thank you very much. Your work is very exciting and important. We look forward to your future projects. I will return to Professor Dennis at the end of the program to discuss her recent Cochrane review. It is my pleasure to welcome Terry Brugha, who is Professor of Psychiatry in the Department of Health Sciences at the University of Leicester in Leicester, England. Dr. Brugha has a long track record of highly cited work in the affective disorders. I noted that his first published work in 1982 coincided with my own. He has not slowed down over the years. In fact, his rate of publication continues to accelerate. In recent years, Dr. Brugha has taken a major interest in prevention of perinatal depression. In particular, Dr. Brugha, in collaboration with Jane Morrell, has done very important work on the training of health visitors in the United Kingdom to become sensitive to the identification and management of perinatal depression and to deliver brief interventions. Terry, welcome. Could you tell us about the origins of the idea to use health visitors on a large scale to prevent postpartum depression?
Thank you very much, Mike, and thank you very much for those kind words of introduction. To be honest, this idea was around for a long time, but no one had really worked out how to make it work. Previously, we had conducted a study which involved using mental health professionals, and you may just remember that because I presented that at the meeting of the Marcé Society that you hosted in Iowa many years ago. There were a number of problems with that. The refusal rates at entry were quite high. There was also quite a bit of dropout during the study, so although we collected outcomes on most of the women we wanted to, many of them had not really taken part in the intervention that we were using then. And it wasn't particularly effective, which was frustrating. We then spent a period of time working directly with health visitors and also with midwives, community midwives in particular, in the Leicester area, trying to get a better understanding of the way they work and how we could work more effectively together. And that was part of a project which people listening to this from the UK will remember, the Sure Start work, which was designed to give more support really to very young families, particularly in vulnerable parts of our city. So then we did, having done that, I should say that we have since not only worked with health visitors, which is what today's discussion is about, but also we've done very similar work now with community midwives responsible for women during pregnancy. And the model I'm going to be talking about is equally acceptable there and equally feasible, which I think is very important, and I would like to come back to that later. For those who are not so familiar with the UK National Health Service system, health visitors are a specialist group of staff with broadly similar skills and experiences to nurses. They work in primary care alongside primary care physicians. We call them general practitioners or GPs. And they also work alongside community midwives and in a sense take over from the community midwife when the mother comes home with a new infant. So almost every woman who bears a child in the United Kingdom, England, Wales, Scotland, Northern Ireland, automatically comes under the care of a health visitor who literally visits her when she returns home, taking over her care from the midwife. And she's responsible, or he, because sometimes health visitors are male, but usually they're female, is responsible both for the well-being and the health of the infant, but also of the mother. So our programme is very much about trying to extend their role in the health of the mother particularly, which of course may benefit the infant. But the point about this is that it's a universal service. Everybody, or almost everybody, has access to this and uses it. They don't have to pay for it at the time. It's paid for out of central taxation. And actually even women from high-income families who could afford to pay for their own health care do actually tend to make use of this. So it's a wonderful opportunity to access the whole population at a very critical time in people's lives.
Terry, could you tell us a little bit about how you tested the health visitor intervention and what you found?
Right. Just before I do that, I'd just like to say a little bit more, if it's okay, about the sort of rationale to using health visitors in prevention in relation to postnatal depression. I've already said that it's very important to have a sort of universal healthcare approach because, prevention in most people's minds means working with people who don't have a condition but who may develop it in the future. So it's got to be about accessing people who are well, but it's also about accessing people who are willing to be helped. And this is a huge issue in our sector, which is the kind of mental health, psychological distress sector, if you like. And indeed, the biggest obstacle to prevention work in the mental health sector is poor uptake, due, if you like, to stigma and various related reasons. So just to quote one statistic in the Netherlands, and there's a paper on this in the literature, it's been estimated that only 1% of adults who could benefit from their free depression prevention services. They have prevention depression services throughout the Netherlands, in the cities and the counties and so on. But only 1% of men and women in adulthood actually make use of that who could potentially benefit from it. And the work we've been doing, the take-up rate is anything between 50 and 85%. So we've completely cracked that problem by taking this sort of universal approach, which, if you like, is embedded in universal primary health care. So that's a crucial part of the rationale, if you like.
Great.
And the other thing is that we're working with practitioners, with clinicians who are already very experienced people. They're very good at helping mothers and very good at helping infants. And I think this is why giving them 8 days of training in two things, one of which is to assess depression in the Health Visitor Project postnatally, and to actually be able to directly offer psychological support sessions, which I'll talk a bit more about later. 8 days training seems to be enough for this very experienced group. We have another program in the UK, which some people know about, which is making access to psychological therapies much more widely available in primary care. But the training takes many months because they've recruited graduate psychologists who've no experience to do that, which we think is a far less efficient way of doing things, if I might say. And as I say, we've gone on to do this now with community midwives, who are the midwives that women meet up with when they become pregnant and go to their local primary care physician first. The model works in the sense that it's acceptable, the midwives like it, and the women themselves, we had actually a higher acceptance rate in that group. So looked at from what I would call a public health perspective, which is the last point I'll make about the rationale. From a public health perspective, what we have is a universal prevention and early treatment, early intervention model that is highly acceptable to women and, if you like, patients, although most of them are not really patients, and also to clinicians who are not otherwise trained in mental health skills. So to really answer your question about how we tested this, if I could move on now and talk about the Ponder study, and this was led, of course, by Jane Morrell, who you mentioned at the beginning. And that was a study across a very large part of England, sort of a population area of about 5.5 million people in the sort of middle of England, towards the east side of the middle of England, what we call the Trent region. And that study, the Ponder study, was designed to answer a very simple question, which is, are women who test positive for depression, that's using the Edinburgh scale, at about 6 weeks after childbirth, 4 to 6 weeks, are they more likely to be test negative, in other words, below the cutoff, 6 months after childbirth, if they are under the care of a health visitor who's had this extra 8 days of training in assessing depression and in providing a limited number of sessions, either based on a sort of cognitive behavioural model or indeed based on a person-centred counselling type model. So we had those two models. And what made looking at prevention in this trial possible was something which was quite curious and very unusual in trials. Most trials like this spend a lot of effort and time and money on identifying within a very large population a subgroup of people that they're really interested in looking at. In this case, it would be women with early postnatal depression. And then they forget about all the other people who agreed to take part in the study who are test negative at point of entry. We didn't do that. We actually collected outcomes on all the women who agreed to enter the study, provided they stayed on board with the project. So we had outcome data on all participants, and not just those who were primarily interested in terms of intention to treat analysis. So we worked away at that, and Jane Morrell did a hugely difficult job in recruiting about 2,500. It was actually much more than that. I mean, they actually spoke to about 6,000 women initially, but I think we ended up with just under 3,000 women who actually initially entered the study. And when we sat together sort of 3 or 4 years later to look at the results, which were presented to us in a very formal way by the statisticians. None of us had any access to the results until the field work was finished, so we're very strict about that. We were presented with the outcomes we were primarily interested in on the women who were at risk and who were supported by the health visitors. But we also had outcome data on all the other women in the trial. In other words, we had outcome data on the whole population, as well as the high-risk group who were test positive postnatally. And I noticed that the effect sizes, the odds ratios, were almost exactly the same in both groups. And I will never forget that meeting. It's probably one of the most important, certainly, research meetings I've ever been involved in my life. But nobody else at that meeting seemed to be paying any attention to this, what I call this bigger picture. Now, I, of course, had been working, as you know, for quite a long time then, for at least a decade then, on prevention. I'd also, in my training, had training in public health and epidemiology in the London School of Hygiene and the Institute of Psychiatry. So I was kind of looking out for these kinds of effects. I was aware that this kind of thing could be very useful and interesting. And I raised this at the meeting, and it was agreed that I would put together a plan for analysing the data to look at this specifically, if you like, a sort of secondary analysis, and that I would potentially put together a paper, which is now, of course, in psychological medicine and which is quite widely read and quoted. And essentially what we showed, and this is getting down to the key result in terms of prevention, is that the women who were test negative at entry, that's at 6 weeks after childbirth, who were okay on the Edinburgh scale, those who were in what we call the control clusters, so their health visitors didn't have any extra training, they were just cooperating with the study and with recruitment. About 11% of those had moved on to being test positive by 6 months after childbirth. But in the 2 intervention clusters, only 8% of them had changed to being positive. So that's a reduction from 11% to 8% in the women who were test negative immediately after childbirth, which is about a 27% reduction in prevalence. And it's population level data. I've never in my life, and I've been studying depression and the epidemiology of depression since I began to do research in the late 1970s, I've never ever seen any evidence that you could reduce the prevalence of depression in a population by that much. So the other things, there are a few other outcomes which I think are actually interesting if I could just mention them. One of them was that this advantage to being under a health visitor with this extra training was still present at 12 months and indeed at 18 months because we had an 18 months follow-up, although that was limited to relatively few women. The other thing which is really curious about this, I'll just remind people, is that these health visitors wouldn't have been offering extra psychological support sessions to these women because they were test negative. So what in effect these women were exposed to is not psychological therapy sessions. What they were exposed to was a health visitor with all this extra training, only 8 days of training. Another thing about the results which is quite interesting, I think is worth mentioning, is that the person-centred counselling approach and the cognitive behavioural approach were equally effective, both in the high-risk women and in the whole population. And the last thing, which I think is a very important signal as to what's going on here, was that fortuitously embedded into this experiment, this cluster randomised controlled trial, this experiment, was a second experiment within the women in contact with the trained health visitors. And a random half of those actually had an Edinburgh scale sort of completion interview conversation with the health visitors. And of course they were all test negative, so that was a nice conversation to have because the health visitor was discussing each of their symptoms with them verbally because they were trained to do this, and then saying, but it's okay, you're test negative. And what we think is that this signaled to these women that if they had any difficulties later on in the following years, any time up to actually the time their child started at school, because in theory they can have contact with a health visitor any time until the child starts at school. That health visitor they could go to. They already knew this person. This was somebody who helped them with the health of their child and with their own general physical health. It didn't mean they needed to be referred to somebody else. So there's another sort of stigma involved in that. And we think that was hugely reassuring. And in fact, we've done qualitative work in the project we've done since with community midwives. And that is one of the things that the women in that study comment, that although it didn't matter to us at the time, we felt good that we knew this was somebody we talked to about those difficulties, because we did worry that those things could happen to us. So there's no stigma, there's no threat of being exposed, if you like, which is what people worry about. No onward referral to a doctor, a psychologist, a psychiatrist, which makes us look bad, but there we are. This is what people fear. This is why so few people take up these things. There was the potential for help if needed. There was a sense of hope, if you like. And I suppose another underlying concern that women have, both in pregnancy and when the child is born, is whether they will be allowed to continue to take care of the child. And we felt that that again was something that they would be reassured that they wouldn't have that taken away from them, because they trusted their health visitor.
Well, this has been Professor Terry Brugha from the University of Leicester. Professor Brugha, thank you very much. This has been a terrific conversation, and best wishes for more success in your work on the prevention of perinatal depression and anxiety. So Cindy Lee, you've done a lot of reviewing of the literature on the prevention of postpartum depression, and you've just published the recent Cochrane Review. Could you just expand a bit on your comments and tell us what you've learned from that review, and what are the take-home messages?
So I recently updated a Cochrane systematic review that I initially started to work on in 2002 and finished that in 2004. We published it in BMJ in 2005, but that was fairly dated, so we've updated it, added additional trials, and now published it just last year. And it's now, this is a Cochrane review that looked at psychosocial and psychological interventions for the prevention of postpartum depression. I targeted psychosocial and psychological interventions because they really clearly address many of the risk factors for postpartum depression. And in this updated Cochrane review, we have 28 randomized controlled trials. And what we found is that psychosocial and psychological interventions, if we apply this to new mothers or mothers in the pregnancy time period, that we can cut the risk of developing postpartum depression by 22%. So there is potentially a place for these types of interventions in our current healthcare system. I also examined in this Cochrane review about how best to apply these interventions to have a preventative effect. And the research suggests that diverse healthcare professionals can provide the preventative intervention. There was not a single healthcare professional group that stood out as being more exceptional in providing a preventative effect when they're providing this intervention. That individually based interventions tended to be more beneficial than group-based interventions. Interventions that were initiated antenatally did not have a preventative effect, or if they were initiated antenatally and carried into the postpartum period, we also did not see a strong preventative effect. But the most beneficial interventions were those that were initiated early in the postpartum period. And that's probably because we don't know how to reliably identify mothers antenatally, so during the pregnancy, who are currently asymptomatic. And thus, we can identify mothers who will then develop postpartum depression. We just don't know how to reliably do that right now with strong or high positive predictive values of any sort of tool. So my recommendation is to look at interventions early in the postpartum period and identifying mothers with potential depressive symptomatology. And I say potential depressive symptomatology because the Cochrane review also suggested that interventions that identified mothers as at risk were more likely to have a preventative effect than a universal preventative intervention. My research has also indicated that if we were to do further research in this area, that secondary preventative interventions seem to be the way that we should be focusing. The interventions that were most likely to have a preventative effect were interventions that provided early professional support in the postpartum period, were interventions that were based on IPT, interpersonal psychotherapy, and telephone-based peer support. Those were the most beneficial interventions.
Cindy Lee Dennis, thank you very much for joining me, and I really appreciate the great work that you've been doing, and looking forward to seeing more of your work in the future. As I hope that you've gathered from this program, there are many exciting developments and efforts to prevent postpartum depression. This work has been carried out around the world, and this program has only touched on a few of those efforts. This educational video, sponsored by the Marcé Society, is the first in a series, and I hope that you will join us in the future as we discuss issues important to perinatal mental health, such as perinatal depression screening, optimizing maternal-child health in the context of maternal depression and antidepressant use, and risk-benefit decision-making for antidepressant use during pregnancy and lactation. Thank you again for your interest in the work of the Marcé Society.